that it causes osteoblasts to produce VEGF. Now, in the pilot study, we also used a collagen membrane. I chose that because I was afraid that TCP particles might migrate, but the membrane itself will guide cellular growth and facilitate stabilization of the blood clot. So let's look at a control. In this study, we're in Texas, so we were only using Texas-sized defects, and so you had to get into the study to at least have a 4-millimeter width and depth of recession. So after root surface biomodification, root plane scaling, we're doing full thickness flap because we're going to try to regenerate not just tissue, but we want to regenerate attachment over this. So full thickness flap to a couple millimeters apical to the osseous crest. I'm sorry, this is partial thickness. This is our control. I have harvested my connective tissue, placed it over there, coronally advanced my flap. And at 3 months, a very nice result, 100% root coverage on both of these teeth, a little stain from the chlorhexidine mouth rinse. Same patient, opposite side. We're going to do our root plane scaling, our biomodification. Now we're doing our full thickness flap I just described, placing a little of the PDGF on the root surface. And we've already hydrated the TCP with the PDGF. You need to do that at least 10 minutes ahead of time because you want the PDGF to bind to the TCP. Now we're going to place that onto the root surface. Now, this is biosurgery. This is not a passive graft. There's a lot going on at the root surface here. The PDGF is causing cementoblasts to come onto the root surface, osteoblasts. It's causing bone to be deposited, cementum to be deposited, organizing PDL, and ultimately an attachment apparatus. Now, it's one thing to draw these pretty illustrations, but can you actually do that? And I'll show you human histology in just a moment. It's even prettier than the illustrations. We place our membrane over that, hydrate that with the PDGF, coronally advance the flap, and our result at 3 months. 100% root coverage, very aesthetic result, no visible signs of inflammation, very little probing depth. All of these have about 1.5 millimeters probing depth. And if you compare our control versus test at 6 months as it continues to mature. As a clinician, I'll take either of these. But we were able to achieve this without a donor site. And if we look at one of our other patients in the pilot, again, a very similar result at 6 months. This is the PDGF graft. That's a connective tissue graft. It's a little more aesthetic. It's not quite so bulky. And so we concluded that both procedures predictably achieved root coverage. And at the end of 6 months, all patients tested and control had no more than 1 millimeter of recession. Tissues appeared healthy and stable, but the test grafts appeared less bulky and more aesthetic, and that provided proof of principle that this is possible. But we needed a bigger study to show, is it predictable? So we used that, and we moved into a larger study that we just published this last year in 2009 in Journal of Periodontology, that we looked at both clinical parameters, but very importantly, we looked at human histology to see what type of attachment are we getting to the root surface. And we did this in collaboration with Peter Schupak, who happens to be lecturing at this very moment in another room. 30 patient, 6-month study. A primary efficacy parameter was recession depth. Secondary efficacy parameters, clinical attachment level, probing pocket depth, width of keratinized tissue, percent root coverage, color, texture, aesthetic satisfaction, and pain and discomfort. And at 6 months, the only factors that had any statistical difference was recession depth and percent root coverage and pain and discomfort. And again, recession depth and percent root coverage are the same thing, just expressed in a different way. At 6 months, the connective tissue graft achieved 98% root coverage. The coronally advanced flap with the PDGF achieved 91% root coverage, again in the high end of the expected range. And the pain and discomfort came out in favor of the test graft, as you might imagine, because there's no donor site. We learned a few things in our pilot study, so we're doing it a little different in our this larger study. Again, just marking the CEJ with a pencil. We're going to root plane scale, biomodify the root surface, full thickness flap. I'm putting a little PDGF on the root surface. I've hydrated the TCP. Now, one thing that we did in the larger study was we're not putting as much TCP here. You see, in the pilot study, we put a big mound of it here. And in this study, we just want enough TCP there to keep the tissue from collapsing onto the root surface. And when you see the histology, you may decide you want even less of that TCP in there. But that's the way we did that. We also learned, following the pilot study, but before this study, that you don't want a cell-occlusive membrane when you're using a biologically active molecule. BMP, PDGF, probably doesn't make any difference. If you're using a biologically active molecule, you need access to the periosteum, to the blood supply, the cells, and so you don't want to use a cell-occlusive membrane. So in this study, we didn't. We used a collagen wound dressing, and again, since we're using trade names, evidently, we used Collotape. Goes away very quickly. So here is the Collotape in place. I'm putting the PDGF on that after I put the TCP over the root surface, currently advanced the flap, and here is 100% root coverage at 6 months compared to before, and you compare that to the connective tissue control. Another patient, this is our PDGF graft versus the connective tissue. Again, a very equivalent result. PDGF is perhaps a little more aesthetic. And again, we're including harder to treat mandibular teeth in our studies as well. And it's particularly difficult to get a good result when you, on a mandibular case, if you have multiple areas of recession, but you're only treating one tooth. And so here is the before with the PDGF graft. Very nice result on this bicuspid here. And again, very nice result with the connective tissue graft. Now, anytime you are doing a study or you and I are treating patients where we're trying to cover root surfaces, there's 3 goals. Number 1 is to restore the functional part of the periodontium, and number 2 is to restore the aesthetics. And I think I've shown you that we've been able to do both functional aesthetics through test or control. And in fact, everything you have seen throughout this entire conference shows that basically whatever you use in there, you're going to be able to achieve these first 2 goals. What we don't know with many of these other materials is the 3rd goal of regeneration over previously denuded root surfaces, and that's true regeneration. And while both our test and our control clearly accomplished the first 2 goals, there were clear differences in regeneration between the 2 materials. So as part of this study, we also had 2 patients that were to undergo orthodontic treatment, and they needed bicuspids extracted. One patient needed 4 bicuspids extracted, the other patient needed 2 bicuspids extracted. So it gives us a nice ethical way to get human histology, because the study then pays for orthodontic treatment that they wouldn't have been able to receive otherwise. So here is day 0. We're going to go in, and I'm going to create our recession defects. Now, I want to end up with 3 millimeter recession defects. And so if we're measuring from the CEJ, that means I've got to remove the bone 5 millimeters from the CEJ, because you've got to have room for that biologic width. And then I'm going to apically reposition the free gingival margin to 3 millimeters from the CEJ. And so this is how it looks at 2 months. And what we did was we created these defects, and then we just let them be in the mouth for 2 months so that the lesions become chronic. And then at 2 months, we went in and we grafted these. And I marked, you can see the little dot here, I marked at the original free gingival margin with a high-speed finishing burr. I also marked at the alveolar crest with a high-speed finishing burr, so we could look at that histologically. And we then grafted it, and here's how it looks at 9 months. And so at 9 months later, or 11 months from day 0, we removed the tooth in block. 1 tooth in each patient had received connective tissue as a control, and the rest received the PDGF graft. We then closed those defects where we took the teeth out with mineralized freeze-dried bone and PDGF, and then the patient went into orthodontic therapy, and the defects were closed orthodontically. Now, we found that we were 100% successful in those first 2 goals. You know, we achieved aesthetic success. All test and control achieved 100% root coverage. But clear differences in regeneration. We got regeneration in 4 of 4 defects with the PDGF, and neither with the connective tissue. So you see the little dot here. This is at the original free gingival margin. Here is the dot at the alveolar crest. Here's 9 months later after the graft. Here is when I remove the tooth in block. Now, I want you to put your Superman glasses on, and we're going to look right through this, and we're going to look at a micro-CT. These micro-CTs blow me away. It's such cool technology. So you're looking through here, and here is the bone underneath that. Now, this little dot, that's the dot at our original free gingival margin, and here, of course, is a CEJ. So we've got root coverage all the way to the CEJ. Now, you can't see this dot because all of this bone has grown up over the previously over this root surface that was previously exposed. Now, I have to tell you, when I first saw this, although I was impressed, I was frankly a little disappointed. I said, you know, that really looks good, but gee, here's a CEJ. Why didn't we get more bone growth? And it wasn't until I kept lecturing on this and thinking about it that I figured out, you know what? That's as much as you can physically get. Because here is a ground section of this. Here is our long junctional epithelium, which ends at the coronal portion of our gingival notch. And then we have connective tissue attachment down to our regenerated osseous crest. Does that look familiar? You know, you got to have 1 millimeter of sulcus, 1 millimeter of our long junctional epithelium, 1 millimeter of our connective tissue. That's the biologic width. So it's physiologically impossible to grow any more bone than what we grew over that. Took me a while to figure that out. Here is the ground sections of that. You see a nice uniform space for the PDL. We have old cementum, new cementum, Sharpie's fibers, functionally oriented PDL, Sharpie's fibers. Another patient, I'm marking at the original gingival margin with my high-speed finishing burr. I create my flap. I've marked at the alveolar crest. It's grafted. We remove the tooth and block. Look at all the bone that's grown down over that root surface. You can't see this dot here anymore. That is the little dot at the free gingival margin. And again, if you look at the, we left space with our TCP here for the biologic width, and that's exactly what we're getting. We are getting regeneration to the limits of the biologic width. And we're not just getting a little bit of regeneration. Again, if you look at all the literature out there that on covering denuded root surfaces that report how much regeneration they get, most of them don't report quantitatively how much they get. You either say we got it or we didn't. Those that report it quantitatively, it's usually in the 0.5 millimeter range. We're generating 2 to 3 millimeters of bone over this root surface. And again, as a clinician, that's not only statistically significant, that is clinically significant. Here is that case. You see a clear differentiation between the old bone. Look at all this new bone that's grown down over it. Look at this uniform space for the PDL. And in high power, here are our osteocytes. You can see the Sharpie's fibers, PDL. Here's cementocytes, new cementum, old cementum. And in polarized light microscopy, here's your dentin, old cementum, new cementum, Sharpie's fibers, PDL, Sharpie's fibers, new bone. You know, I go to a lot of these meetings where people are showing histology, and you have to kind of squint and say, well, I think I can tell regeneration has happened here. There is absolutely no doubt this is true periodontal regeneration like you've not seen anywhere else. Our other test case, tooth removed in block. Look at this polarized light microscopy. New bone, functionally oriented PDL, new cementum. Look at those Sharpie's fibers. You think you're going to pull that graft off of that root? There's no way. You know, that sucker's firmly bound down. Now, to compare that to the two controls. Here's our mark at the free gingival margin, our mark at the alveolar crest. I achieved 100% root coverage. I'm a believer in connective tissue grafts. Those suckers work. But let's see what's underneath. So here's our complete root coverage. Put your Superman glasses on. Whoops. Nothing over that root surface. For the very first time on the micro-CT, you can see the notch at the alveolar crest just like it was the day I did that graft. It almost makes me also wonder, you know, about the literature when we're learning about doing osseous surgery, and you always lose a little tissue when you lay a flap. Man, this looks like it's exactly the way it looked that day of surgery. If you look at the ground section, yes, we achieved 100% root coverage, but we have a long junctional epithelium running all the way down close to the osseous crest, a nice connective tissue adaptation. The other control, very similar thing. We've got long junctional epithelium running all the way down here, no regeneration. Look at the denuded root surface. And I think these two slides really tell this tale. I think if you look at all of the activity on the root surface here with the PDGF group, look at all the bone that's growing up over it. Look at these two root surfaces here. Again, this looks exactly like it looked that day. Exactly, and this looks exactly like that. Remember this patient in the pilot? Well, he came in to see me 3 years later. We're showing very nice root coverage at 3 years. Well, he had a periodontal abscess in the molar just distal to that, and he gave me permission to do a little peekaboo here. So at 3 years, we see we have 3 millimeters of bone gain, and this is in a naturally created or naturally occurring recession defect. I showed you this works in surgically created defects. Here we have one in a naturally occurring defect. I think what we're showing you is simply revolutionary. I think that the future is bright, both for us and our patients. We're going to be able to do things in the very near future we could just dream about in the past. We're going to be able to provide outcomes that are more predictable, less invasive, and more robust for our patients. Thank you very much for your attention.